Very much, my good friend and colleague, Professor Raj Azad, also to the President, Dr. Raju, all members of the organizing committee, and a great congratulations on this wonderful event, and also on the occasion of the 70th Congress of the All India Ophthalmological Society. I also send greetings from my home society, the Singapore Society of Ophthalmology, as well as the College of Ophthalmologists from back home. It's a great privilege for me to be here in Cochin, God's own country. It's my first visit, but I hope not my last. And also, I think it's an important topic that I've been asked to share with you. You heard this morning from a wonderful speaker, visionary, Professor Badrinath, about the burden of diabetic disease on the eye, in particular, diabetic retinopathy. And so I thought it would be appropriate to tackle the paradigm shifts that have occurred in our understanding of the management strategies for diabetic macular edema, which remains today probably the most important cause of blindness in diabetics. I think you're well aware that there are two major causes of blindness in diabetics: proliferation, which ultimately leads to vitreous hemorrhage, tractional detachment, and neovascular glaucoma. But I will not be touching on those topics in great detail. My emphasis today will be on the management of diabetic macular edema and how there have been changes in the concepts of management. If you go back 2 to 3 decades, it is without doubt that laser photocoagulation has been one of the most successful, the most remarkable therapies in our time in ophthalmology. Solid evidence from the diabetic retinopathy study as far back as the 70s and the ETDRS study in the 1980s show us the power and the durability of laser photocoagulation in preventing blindness. And so all of us have been brought up and been trained in the use of laser photocoagulation. It is now one of the foundation stones of our ophthalmic training, and with very good reason. And you can see in this example a patient who looks desperately hopeless, hand movements, vision, a horrible retina, and one would never imagine that laser photocoagulation can lead to a reasonably good outcome. In this case, visual acuity improves to 6/24, obviously with a lot of macular ischemia, but really a reasonable outcome considering his pre-morbid state. Also for diabetic macular edema, laser photocoagulation has stood the test of time. If you look at the first group, where the fovea has been thickened, or foveal involvement has already been shown, and you know that visual acuity is usually much worse, without treatment, 1 in 3 patients will have significant visual loss. And with laser photocoagulation, either focal or grid laser done in accordance with the ETDRS guidelines, you have a 60% reduction of visual loss. That means 13% visual loss. In other words, although it has been very successful in reducing visual loss, a significant proportion of patients still have significant morbidity. Of course, if the fovea is not involved, then without treatment, only 16% experience significant loss, as opposed to those with treatment, there is a 10% reduction. So there are clearly advantages of laser photocoagulation, among them the proven benefit that have stood the test of time, good, reliable scientific evidence in prevention of visual loss in both proliferative diabetic retinopathy as well as clinically significant macular edema. But all of you as practicing clinicians will share some of my frustrations with laser photocoagulation. We know that the onset of action is often delayed, sometimes as long as 3 to 6 months after initiation of therapy. Some patients experience a severe worsening of vision after starting therapy, and this creates a lot of loss of confidence. And often some of my patients who have absconded treatment have done so mainly because they felt that treatment made their vision worse. In diffuse type of CSME, vision often remains poor regardless of what you do. So the treatment is really at preventing further visual loss, but not so much in gains in vision. We know that conventional pan-retinal photocoagulation may also worsen or aggravate macular edema, and of course there are side effects associated with PRP, visual field defects, night vision loss, accommodative problems. And so really the revolution has occurred in the past 5 years with the introduction of pharmacotherapy. These have been used in conjunction with laser therapy, and these include steroids, either applied in the subtenon space or intravitreally. We had a lot of experience with Kenalog or triamcinolone. In fact, as long as 10 years ago, Raj and I have been presenting cases of limited success of triamcinolone delivered intravitreally. More recently, we have seen other methods and other steroids being introduced, for example, in implantable forms like the Ozurdex. But really what has changed and has made things much more exciting for both general as well as retinal specialists is the availability of anti-vascular endothelial growth factors. Among them, we had Macugen or pegaptinib, Lucentis or ranibizumab, Avastin or bevacizumab, and very soon to come, aflibercept, which is a VEGF trap agent. There are advantages of adjunctive intravitreal therapy. Rapid onset of action is usually very dramatic. Patients feel the improvement usually within a few days, sometimes within 24 hours of injection. It eliminates the initial worsening of vision, which we see with even judiciously applied focal or grid laser photocoagulation. Patients are often satisfied, they gain confidence. It is useful for medial opacities like vitreous hemorrhage or significant cataract. And of course, rapid control of neovascularization, both in the retina as well as in the iris, control of intraocular pressures is also very useful, especially in proliferative disease. It makes for safer macular laser and ultimately safer vitrectomy surgery. But these come at a cost. They are invasive procedures, potentially blinding complications like endophthalmitis have to be emphasized to patients. And very often these drugs have short-lived effects. It ranges from 1 month for the anti-VEGF agents to 3 up to 6 months with the triamcinolone or dexamethasone implants. There are worries about neuroprotection. We know that VEGF, as a natural growth factor, is critical in the survival of neuronal tissue. And it's also important in normal retinal perfusion. So with repeated injections of these anti-VEGF agents, are we in fact making things worse? And this is not even touching on the recurrent cost that is involved. Now let's first deal very quickly with the role of corticosteroids. We know that they work because they enhance the barrier function, they close up the tight junctions of the endothelial cells, they prevent leukocyte migration, inhibit prostaglandins and other inflammatory factors, and to a limited extent, they also inhibit VEGF. So these are relatively well documented effects of steroid. What is not widely known is that there are many relative potencies of corticosteroids, and we've been using mainly triamcinolone, which is actually a far weaker steroid in terms of potency to something like dexamethasone, which is almost 5 times more potent than triamcinolone. But triamcinolone still remains more widely available. It is easier to inject rather than an implantation device, and it's much cheaper. The DRCR-NET looked at intravitreal triamcinolone in comparison with standard laser for diabetic macular edema. And this was really quite fascinating. All of us expected that the drug, in this case triamcinolone, would turn out to be more effective in terms of visual outcome, but it's not so. Here, with this study, at 2 years, in fact, laser therapy had a better visual outcome than either 2 doses of triamcinolone, either 1 milligram or the more standard 4 milligram dose. So indeed, it was statistically better than both doses of steroid use. And if you look at the progression of visual acuity, you see that the 4 milligram triamcinolone increases vision quite quickly, usually within 3 to 6 months of injection. But then it starts to fall off and falls off quite significantly. And the two reasons for these are cataract formation as well as intraocular pressure rise. With the OCT, we see a very slow, gradual, but prolonged reduction of the mean macular thickness with laser photocoagulation. So maybe with diffuse CSME, focal and grid laser do not work as quickly as triamcinolone, but in the long run perform better. But just look at the effects of pressure once you have injected 4 milligrams of triamcinolone. 30% of patients at 3 years will require some kind of IOP lowering drug. So the significant morbidity of steroids in the longer term, beyond 2 years, cannot be underestimated. Here in the probability index, the cumulative incidence of cataract exceeds 80% after 3 years of treatment with triamcinolone. So clearly the message is, between laser photocoagulation and triamcinolone injections, laser seems to achieve better outcomes with fewer complications. Now, does changing the steroid preparation improve the outcome? In this case, Placid looked at the implantable dexamethasone device. Remember, dexamethasone had a higher potency than triamcinolone. The study design was very simply a sham versus a treatment arm, and rescue laser photocoagulation could be applied within 1 month. Patients with at least 2-line improvements seem to have a much better proportion of patients in those who received the dexamethasone implant. And certainly within the first month, there was a significant difference between the sham group and the treated groups. But look at what happens in between. At 4 months and 6 months, the difference starts to drop off. So the initial effect of dexamethasone is quite dramatic, but by 3 months, the effect wears off, and in fact does not differ significantly for those patients who did not receive the implants. Then when you put these implants in again, that means they are re-implanted with dexamethasone, again the visual acuity picks up. So it does not last, and you see this very clear seesaw effect depending on when you implant these devices. This is mirrored in the central retinal thickness. It drops when you implant the device, and then the effect wears off very quickly, and by 6 months you need to implant it again. What happens with the intraocular pressure? Well, slightly better results than triamcinolone. Here is a 15% chance of patients with at least 10 millimeters mercury rise in pressure. It is not insignificant. So we still have to consider whether it's worthwhile implanting these devices with short-lived effect and still living with the consequences of raised intraocular pressure. Again, the intraocular pressures here were significant, but cataract did not seem to be significantly increased, at least at 12 months. But really, if you go down the road 24, 36 months or more, I'm quite sure that the cataract numbers will increase. So let's turn now to VEGF. We know that VEGF is both present in physiologic as well as pathological states. Physiologic mainly for wound healing, embryonic development, normal physiological functions like ovulation, menstruation. But more specifically, we talk about the function in the eye. It is essential for retinal perfusion and neuroprotection. In pathologic states, we see this clearly in diabetic retinopathy and others like macular degeneration. Aiello's group were very instrumental in showing us the proof of principle that VEGF is upregulated in active diabetic disease. Of course, there is more VEGF in proliferative disease than non-proliferative diabetic retinopathy. Adamis also showed that if you block the effects of VEGF, you can inhibit, in this case, iris neovascularization, and in many other preclinical models, inhibit retinal neovascularization. Here was a very elegant study in the early days of anti-VEGF use. Here with pegaptinib given at 6-weekly intervals up to 30 weeks. And you see in the treated group, these new vessel tufts disappear. Now, 6 weeks after the treatment is stopped and these patients continue to be observed. You see the new vessels starting to slowly come back. So by the end of the first year, after having treated them for 30 weeks and then stopping, these new vessels come back as if nothing had happened. It taught us that anti-VEGF agents like Macugen could inhibit retinal neovascularization and cause regression, but they did not remove the underlying stimulus, because these vessels will come back once you stop therapy. Compared to, of course, no treatment, there was even worse progression of new vessels. Increasingly, patients have been receiving anti-VEGF agents like bevacizumab in proliferative diabetic disease, not just to control neovascularization, but to also make surgery safer for those who have been scheduled for PDR treatment. More recently, attention has been turned to the use of anti-VEGF for diabetic macular edema. We still do not know what is the duration and frequency required for treatment. How long do we have to continue treating these patients? Long-term blockade of VEGF is still a factor to consider. There is decreased neuroprotection. There are reports of impaired retinal circulation, enlargement of the foveal avascular zone, especially with very repeated treatments. Is there a difference between complete VEGF blockade versus partial blockade? For example, Macugen only blocks the 165 isomer of VEGF compared to all isoforms with the other agents. And I want to spend a little bit of time later to talk about systemic concerns in already high-risk patients. Now, the proof that anti-VEGF agents works well for diffuse diabetic macular edema comes from the pivotal trial involving ranibizumab in center-involved diffuse edema. RIDE and RISE, and at the end of this year, I'll be reporting the results of REVEAL in Asian patients in exactly the same protocol. These patients were randomized into 3 groups: a sham injection, a 0.3 and a 0.5 dose of ranibizumab or Lucentis. Rescue laser could be applied within 3 months after the initiation of the trial, and these patients were then followed up for 3 years. But the results clearly show that anti-VEGF agents like ranibizumab can give you dramatic improvements in vision not seen with laser photocoagulation. Here you see a net increase in at least 2 lines of letters by 24 months with continued increments in visual acuity that can be maintained. But remember, these patients continue to receive monthly injections of either 0.3 or 0.5 milligrams of ranibizumab. Here too, some dramatic results, improvement of at least 3 lines at month 24. There is a over 40% chance of patients receiving ranibizumab of achieving a doubling of their visual acuity compared to only 12% in patients who did not receive ranibizumab. This is reflected also in the changes in the OCT, the best reduction in central macular thickness seen in the anti-VEGF treated groups. In terms of ocular adverse events, it was heartening to note that endophthalmitis rates did not increase with ranibizumab compared to sham. However, if you look at the systemic side effects, I think there is some cause for concern. Now, overall, statistically, there was no significant difference between sham-treated groups and the ranibizumab-treated groups, which is fine. But if you look at cardiovascular events like CVA and stroke, you see here that there seems to be a trend towards a greater incidence of stroke. And certainly, if a patient has had a history of cerebrovascular event, it is important to counsel patients accordingly, perhaps consider a lower dose of ranibizumab, because the risk of stroke can be increased as high as 9 to 10 times. Similarly with deaths and other events, they were not statistically significant, but I think it's important to put that into perspective. Finally, a comparison between ranibizumab and triamcinolone for diabetic macular edema. This was another DRCR net trial with 4 arms: laser alone, combination laser with prompt laser. Deferred laser is up to 6 months after you have started anti-VEGF treatment, and then finally triamcinolone. And just to summarize the results at 52 weeks, 1 year, clearly the best results were seen with those who were treated with ranibizumab, either with prompt laser or deferred laser, and by about 2 years, the best results were seen in ranibizumab with deferred laser. That is, you don't need to start laser therapy immediately. So the changes in visual acuity are reflected here. The best results were with Lucentis and deferred laser. And similarly, the mean change in central thickness on the OCT was seen best with the ranibizumab deferred laser group. Now this of course remains a problem. Overall, in 2 years, the median number of injections is still very high, whether you use laser or not. 8 injections for prompt laser group, 9 injections of Lucentis with deferred laser. So it's important to tell patients that overall, the burden of injections is not significantly reduced with laser. There is also an added advantage of using anti-VEGF in terms of reducing progression of diabetic retinopathy. Here you see that there is an improvement of DR levels by at least 2 levels in 25% of patients treated with Lucentis. So to end, the current guidelines for proliferation are quite simple. I think laser photocoagulation remains the gold standard. Anti-VEGF is useful in certain special circumstances. Here with poor ocular media where you cannot place sufficient or adequate laser photocoagulation, those with rubeosis where you have to control the neovascularization very quickly, for preoperative stabilization, and those who have coexistent diffuse CSME, because you know that extensive laser can worsen CSME. Now the current guidelines for diabetic macular edema, especially those with central involvement, that is the fovea is already thickened, is firstly to optimize glycemic control, manage coexistent disease like renal impairment and hypertension. We would treat center-involved DME more aggressively because their rate of visual loss is more significant. If it is a focal leakage point, say you see a succinate ring, treat it with focal laser and they do very well. But those with diffuse diabetic macular edema would require anti-VEGF first of all, and you may consider adding laser photocoagulation later on. For non-responders, so this would be third line, you would consider steroids like what we have mentioned, especially if these patients have already had their cataracts removed. And finally, this is what my current logarithm of treatment is. Control all the coexistent factors, especially blood pressure and blood sugar. Focal disease, treat with laser, focal laser. Diffuse disease, I start with an anti-VEGF agent like Lucentis. And then to repeat the OCT. Of course, the OCT will tell us whether there is a significant tractional element. If there is, then surgical intervention will be required. But most cases would respond to anti-VEGF. And then later on add modified grid or focal laser in the style that the DRCRnet has prescribed. And then finally, treatment failures can probably be handled with steroids, either triamcinolone or dexamethasone implant. So to summarize, visual outcomes have improved markedly. These are exciting times for retinal specialists because of the various options that we now have. It reflects a paradigm shift from laser photocoagulation or sometimes not being able to do anything for our patients with diffuse DME, now to the era where anti-VEGF agents has become the first-line treatment. It is now established for center-involved diffuse type of diabetic macular edema. It is superior to triamcinolone and grid laser alone. However, there is no substantive benefit in adding laser immediately. There is room and time to do it later on. Significant ocular and systemic safety signals have not been demonstrated, but be very, very wary of patients who are at high risk or who have had a history of cerebrovascular events. However, what remains really is the overall burden. We know that it remains high, and cost will certainly be a big factor in many countries, including India. So really, I think we're very happy that we've moved away from the old days where we had to wait for sunshine before we could effect treatment for our diabetic patients. With that, thank you very much for your attention.